Hi, welcome to our keynote presentation, Prevention of Violence Against Women with Disabilities. I'm Associate Professor Patsie Frawley, and I'm coming to you from the University of Waikato in New Zealand. So, kia ora.
Hi everybody, I'm Dr. Amie O'Shea and coming to you from Deakin University on the lands of the Wadawurrung people of the Kulin Nations. Today, to begin, we wanted to present to you with some introductory information on violence and abuse in Australia. Much of this we glean from the best information which is available about the experiences of violence and abuse, although we do acknowledge it has limitations in relation to people with disability. So I'm referring to the Personal Safety Survey, and some of the concerns that we know exist for the Personal Safety Survey are around how it defines disability and its specific requirement that interviews are conducted in private. When conducted with a proxy, questions about violence and abuse are removed. However, what we do know from the Personal Safety Survey is that in 2016, approximately 33% of respondents who reported a profound or severe disability were not included in the released data due to their use of a proxy or opting out. Lastly, the Personal Safety Survey only collects data from private dwellings, so therefore it doesn't include people living in institutional or service system care settings. Lastly, the way that questions are asked by the survey don't allow us to know whether the person had a disability at the time of experiencing violence, and that means it's not possible to identify if disability is a risk factor for or an outcome of the experience of violence. However, we present this information to you on the slide to give you a sense of the picture here in Australia. We know initially that women, and this we refer here to all women, are much more likely to experience violence at the hands of somebody they know than by a stranger. For women with disability, there is an experience of violence at significantly higher rates, more frequency, for longer, earlier in their lives, in more ways and by more perpetrators. On all of those counts when compared to women and girls without disability. When we look at sexual violence in particular, while all women are at a higher risk of sexual violence than men, women with disability are twice as likely to report an incident of sexual violence over their lifetime than women without disability. Men with disability over their lifetime are also 2.6 times as likely to report sexual violence when compared to men without disability. We also note in this context that, and we will return to discuss this in greater depth, that women and girls with disability experiencing violence also face significant barriers in accessing those critical domestic, family, sexual and community support services that can be appropriately inclusive and supportive of their needs. There are a number of compounding or parallel factors to consider, particularly as it relates to experiences of sexual violence by women with disability. The first quote on the slide here, excuse me, refers to the 2015 Senate inquiry here in Australia, which led to the current Royal Commission into Violence, Abuse, Neglect and Exploitation of People with Disability, where they noted cultures of neglect which were facilitated by a lack of transparency and accountability within service systems which surround people with disability. The University of Melbourne, our colleagues in the Centre of Research Excellence in Disability and Health, produced a report in March 2021, and I include some of their data here just to demonstrate. On the graph you can see that the prevalence of sexual violence is higher for both men and women with disability than their same gender peers without disability. There are also a number of types of violence and abuse that are recognised as being experienced disproportionately by, or even exclusively by people with disability. So this can include reproductive coercion, for example, or other forms of coercion or control, sexual exploitation, withholding or denying access to medication or communication devices. Lastly, we know and we acknowledge the need then to consider the inadequate current knowledge that we have around timelines of disability and violence. That is, we need to understand more about how we can consider people whose disability, for example, acquired brain injury or physical disability, is acquired as a result of violence, and then to also consider people with disability as perpetrators of violence. By taking an intersectional lens, we're able to consider more of the additional factors in understanding the experiences of violence and abuse for people with disability. So the likelihood of violence and abuse for somebody who is Indigenous, LGBTIQA+, or culturally and linguistically diverse is equally increased through those characteristics as it is through their disability. There are then the concomitant issues which happen for those people who are equally not able to access services that are attuned to their needs. Secondly, you can see on the graph here on the slide, which again is taken from the report by the Centre for Research Excellence in Disability Health, the breakdown of prevalence of type of violence, again, since 15 years of age by impairment type. And you can see on the far right, the two clumps at the far right refer to psychological, what they call psychological disability and cognitive disability. And so we can see there that is at 50 and 46% respectively amongst the highest. Equally, we can see that physical violence is the form of violence experienced at the highest rates across all disability groups and also for people without disability. I would suggest that this reporting of sexual violence for women with cognitive impairment particularly is an underreport of our own experience in working in this area. The reason that we talk about types of disability is that it matters because of the particular stereotypes that are accorded to people, particularly people with cognitive disability or people with mental illness. So groups commonly seen as vulnerable, who are often given poor or non-existent sexual education, who are unfortunately positioned often as unreliable witnesses in prosecution or decisions about prosecution of cases, and more likely to be segregated from their community than other people. This segregation includes medical systems of care, and altogether all of these form factors which may also make them a soft target for predators. So I'll just pick up a little bit on the point that I made in the last slide, because how disability is understood is a primary precursor to how sexual violence against people with disability is understood, and unfortunately has a lot to do with how it has been able to continue at such shockingly high rates. When we talk about disability here, you can see that we are about taking an approach which recognises the two-way relationship between an individual and their environment. So we build here on the work done by academics like Tom Shakespeare, who wrote about this as an interactional model of disability. We know it's particularly important if you consider environment in its fullest sense. So not just the buildings, not just access to buildings through a ramp, but the environment composing the people, the policies and the systems which surround an individual. I will say one thing about the physical environment though. We often come across the suggestion that video cameras, that installing security video cameras is a way to protect people who live in segregated care settings. I draw your attention to this review and analysis by Brent Hayward. The reference is in the final slide, where the authors found that there was no evidence at all that installing camera surveillance reliably protects people with disabilities from abuse and neglect in their homes. And in actual fact, camera use may be a sign of possible abuse. I've already talked about the need to consider intersecting experiences or identities held by people with disability. So we need to focus not just on their disability, but to acknowledge and to consider their gender, indigeneity, sexuality, regional location, and so on, when considering how best responding to sexual violence. By that I mean that your policies or processes for responding to any particular group don't then exclude somebody who belongs to that group and also has a disability.
Okay, thanks, Amy. I'm going to take over now and just talk to you a little bit about ways of understanding disability, violence and abuse, and to present probably a model that most of you have seen and understand. And I'm just wanting to contextualise that model too in disability research that has promoted and advocated for the use of this model to shift the idea of violence and abuse and disability away from an individualised, inherently vulnerable kind of discourse to one that looks more systematically and systemically at the intersecting factors of disability and communities that communities' experiences and relationships that intersect and work together and interrelate to really create a story and a true story of experiences of violence and abuse that can be changed and that should be changed. So the World Health Organization report on violence and health and many other documents within the World Health Organization put forward this ecological model, and in its simplest form, this ecological model has a number of layers from micro to meso that look at the interrelated systemic understandings of the way these factors interrelate to increase the experiences of violence and abuse. So at the individual level, for people with disabilities, what does this mean? In our experiences of our research and work that we've done, one of a key issue around the storing of people with disabilities is that they are not recognised or seen as agenic people with their own agency and their own capacity to understand what they like, express what they like and need, and respond to things that they don't like and need. So this is often operationalised through infantilising people with disabilities and also not recognising the sexuality, sexual citizenship, and that people with disabilities are sexual beings. Now, if you put these things together that I'm identifying here at the individual level, another factor is that disability seems to be the primary identity. And as Amie's just indicated, that people with disabilities are people first. They're people of different genders, sexualities, ages, living in different geographies around the world and in communities. And that these things all together tell the story of the person. However, what we see and unfortunately still see in even current research around violence and abuse of people with disabilities is this focusing on some individual characteristic like a diagnosis of a particular disability and you know, really excluding other understandings of people, and that continually the word vulnerable is used as an inherent characteristic of people, particularly those with cognitive disabilities. And an earlier slide that Amie shared indicated that people with cognitive and psychological disabilities are experiencing violence and abuse at much higher rates than other people with disabilities. And I think that one of the reasons perhaps why Amie's and my work has really focused on working with people with intellectual disabilities is in fact this particular issue, is that there needs to be a change in the understanding about what it means to be a person with an intellectual disability or other cognitive disability. And to challenge these ideas of infantilization, you know, asexuality, dependency, and this single story that a person with an intellectual disability is inherently a vulnerable person to abuse. So this ecological model helps us do that by seeing the individual within the nesting of the rest of their world and their lived experiences. So relationally, what happens here with people with disabilities as we see it in our work is that within the relationships and interrelationships people have, there's often a power over kind of context happening in people's relationships. So this follows that thread through from not being seen as agenic and having capacity, that other people in their lives, justifiably sometimes, other people are in their lives to support them and make decisions in relation to and supportive of them. But sometimes these relationships are power over relationships. Relationships that people with disabilities themselves say are oppressive in that they're not recognising their individual capacity to make decisions or even who they are. And this can be carers, families, service providers. And some early work by Dick Sobesy, who I'll refer to again later, a Canadian researcher who changed my experience of thinking about and then having a career and looking at sexuality and abuse prevention of people with disabilities, talked about this and really highlighted that, in fact, within many so-called caring relationships, there is abuse, and that this is an abuse of power as we understand it within other forms of sexual violence and other forms of violence. And that this was a bit of a challenge, really, because the story is people, and the word is, they're carers. Yet there is a corruption of this care. And these are difficult things for us to hear and as a society, I think about. Some of the other issues here are that there are limited opportunities for equal social, familial and intimate relationships for people who have not been perceived as people who have that right and who have that capacity to choose these kinds of relationships. So I think you can start to see the story here that is talking about these interrelated and intersecting experiences that take the focus away from this idea that something like Down syndrome will make you more vulnerable to abuse. So let's stick with this idea for a little bit longer. What happens when we then look at the community, that the community and communities and their response to an understanding of people with disabilities and how this might impact on experiences of violence and abuse? So thinking about it at a community level, people are often seen with disabilities as non-citizens, people who don't have the same citizenship rights, and therefore can have decisions made about or for them, or be totally invisible to their communities. And these are their social, religious, family, and civil communities. Of course, how we've responded to this in communities is through a welfare model that says, well, we'll look after people, or we'll look after some people. But that then carries through to an idea that these people are non-productive. So in a neoliberal society, this is not a good thing. And that if people are non-productive, do we have to care about them that much? Do we have to assign them the same rights and opportunities as other people? So this invisibility actually follows and carries through, for example, to being invisible to violence and abuse services. And that what I mean by that is that often, as Amie's identified through the personal safety survey, people aren't even counted and their experience is recognised because they're not seen as people. So if you think about that personal safety survey, it requires that people are in houses, in family homes, in dwellings where they can be recognised as individuals. That's clearly not the case for many people with disabilities. So we don't even count. And finally, at the meso level, at this societal level, what's happening here in relation to people with disabilities and violence and abuse? So if we follow this story all the way through, what we see is that policies and practices actually reinforce this dishuman perspective of disability. And we understand, therefore, that experiences of violence and abuse can be almost, identified or not identified as real, as actually being the same as for other people. If people don't matter in the same way, then does the violence and abuse that they experience matter in the same way? This has been reinforced in society over time, and I'm not suggesting it's historical, by segregating people and othering them. We've had historically and currently experiences of people being physically segregated in institutions, in residential services that other people with disabilities don't live in schools that other people don't go to. And this segregation reinforces, doesn't it, the idea in society that this group of people are other and different, and as Dan Goodley, a disability theorist, would suggest, dishuman. And then we have laws that diminish their personhood. And later we'll talk about the United Nations Convention on the Rights of People with Disabilities. But a key thing about this convention is that it is trying to change this story. It's trying to change the story all the way back through to the individual to say these people with disabilities are rights holders, and they are the same rights holders as the rest of society. And so I just sort of implore, I suppose, here an opportunity for us all to think about and implore you to think about how, what brings us here today to talk about sexual violence and people with disabilities. It is, as Amie has rightfully identified, that the rates of abuse are much higher. But it's also because we are actually fighting a social issue here. We are looking for social change here that can be brought about by this understanding and aligning understanding of disability, violence and abuse with mainstream understandings of disability, of violence and abuse. And challenging some of these social systems and ideas and strongly held beliefs about disability and shifting those so that we can start to understand the human rights of people with disabilities and advocate for these so that we can change the story that we see around violence and abuse. So over to Amie now to talk a little bit about how we in our work have done this over the past decade or so in Australia.
Thanks, Patsie. So yes, as Patsie said, a bit of a shift of tone now to give you an example of how this ecological approach to understanding disability and towards achieving social change in this area, what that might look like. And so we're drawing here on our work for over a decade on the Sexual Lives and Respectful Relationships program. This is a primary prevention of violence program which is run by, for and with people with intellectual disability. And it's about sexuality rights, respect and preventing violence, drawing on that ecological model that Patsie has explained so clearly. It's based on research conducted by Patsie and myself, and prior to that, Professor Kelly Johnson and colleagues, with people with intellectual disability about their lives. It's a program developed itself in collaboration with people with intellectual disability, including several periods of review and additional research also conducted alongside people with intellectual disability. It's a program that's implemented in local geographical sites by a network of people who come together with the shared aim of addressing the issue and acting to do something about violence and abuse for women with disability. So members of that group might be people with intellectual disability, certainly partner organisations in the area whose responsibility overlaps this area, and what we call program partners, who are community health professionals in roles like sexual health nurse, sexual assault counsellors, and so on, who work in that area within the community in that respect. So those people come together as a site and work together to manage sexual lives and respectful relationships in their area, with support and coordination from the research teams at Waikato and Deakin University. We also make a range of resources available on the website, and you can see that there as well as on the final final slide. So as I said, the program operates within that same ecological model that Patsie has described, and here you can see how that is depicted. This image is often called the onion by peer educators, who are the people with intellectual disability who we work alongside in presenting this and in doing this work. And it's called the onion simply because it has so many layers. What you can see at the centre in the white individual layer is the idea of people with intellectual disability at the centre as change agents, as active members of our fight against violence and abuse, directly challenging those ideas of invisibility, of incapacity and vulnerability by featuring in a very central role. So what that does inherently is to challenge ideas about capacity and vulnerability. It can turn on its head ideas about knowledge, about who has knowledge, how you get knowledge, who's allowed to know it and develop it. We work at the blue level. You can see the blue level of sector development there. We work with program partners who, as I said, are members of local sites who are also involved in a community development, sexual health, women's health type role. And in between those two, you can see the learning partners, who are people in the program participants' life who they might choose to share their learning with in the form of a physical workbook, but also ongoing conversations after the program delivery to continue to keep discussions and connections about sexuality and relationships in their life. You can see at the final orange layer around the edge, there is our work around the research and evaluation. We have worked with this model really successfully in the Sexual Lives and Respectful Relationships program, and also across adaptations to the program that we've made to focus on people with acquired brain injury, and also a project running this program with LGBTIQA+ people with intellectual disability. And the last thing I'll share about the program, because you really can find a good deal of information on the website, is a summary of some of the findings that we've made so far. And again, references are on the final slide. We know that through the use of this model, it has become possible to talk about sexuality, violence and abuse in the lives of people with disability in a different way. I think we've made clear that that different way means moving away from invisibility directly to being at the centre, the visible advocating part of demanding that change needs to happen for people in the community. We've seen how everybody is always learning. A tendency when we talk about intellectual disability is to think of training and education, and that that's the person who needs to receive that, when in fact what we have found is that through this process, through the side-by-side nature of people working together in their local communities, is that learning continues and gets deeper over time. Some of the sites that we've worked with have been established for over 10 years, and we have seen over that time the way that learning deepens and becomes more sophisticated over time as people are involved. We've also seen through those partnerships that are built between people with disability and the community professionals that people with disability are able to show for themselves that they can have a say about sexuality and violence in their lives, that they are actually a rightful part of that work which is about them, that they're sexual beings with sexual agency and the right to respectful relationships, and that their experiences will also intersect potentially with other minority identities, and that might be around, for example, culture or sexuality. There are two screenshots on this slide, which I'll just use as an example for that to you. They are stills from videos produced as part of the project Spring Off, which was for people working with people with acquired brain injury. And these are paid actors who are actors with a brain injury, reading stories that were collected by researchers at Deakin University, looking at collecting narrative research methods to collect stories of lived experience of people with brain injury talking about sexuality and relationships in their lives. And although the captions are a bit small to read, I'll just read them out. The top one, the image with the woman with blonde hair, the captions underneath say, "Don't tell your parents because they won't believe you, they'll believe me." And the bottom image, the close-up of the woman's face, it says, "In my country, brain injury brings shame for the family." These are full and complete stories which are read by the actors and shown on video to group participants, and these are examples of the kinds of discussion points which can be picked out and then led through discussion after the videos are watched during the program.
Okay, so we're going to take a little bit of a turn now and move towards tertiary prevention. And I probably don't have to explain this, but of course, going back to the World Health Organization model on violence and abuse prevention, it sees all work as prevention, so primary, secondary and tertiary. What we've just been talking about with sexual lives and respectful relationships grew from the idea of primary prevention. So thinking about what can we do with particularly groups of people who are more marginalised and perhaps more at higher rates of abuse, experiencing abuse. What can we do to work on ideas, changing attitudes and values, developing knowledge and skills that can hopefully prevent experiences of violence and abuse? Now, I say that hopefully because I would say that anecdotally, our anecdotal experience of working with people in our programs would really reflect what we see in those statistics that we saw earlier, if not higher, of people disclosing experiences of violence and abuse. So whilst we framed it around prevention, we actually knew that most of the participants, most people involved in this, people with intellectual disabilities, throughout their involvement in the Sexual Lives and Respectful Relationships work, will disclose an experience of abuse, and very, very, very much likely that that will be an experience of sexual violence. However, we are talking about prevention all the way through. And so tertiary prevention really refers to what happens when people do experience violence and abuse, and how can we ensure, our work has been about how can we ensure that those responses around those tertiary responses are accessible and effective for people with disabilities, given that they are at such high rates. So one of the things that we've done, 2 projects, one where we looked across Australia at domestic family violence and sexual violence services to try and find out what they were doing and what they understood about their services and their service responses for women, particularly women with disabilities. And that was funded by the Australian National Research Organisation of Women's Safety, and it's research that I did along with Sue Dyson, myself and Sally Robinson, all working in different places now. At that time, Sue Dyson worked at the Australian Research Centre in Sex, Health and Society, and Sally Robinson was at Southern Cross University. Now Sue's retired, Sally's at Flinders, and I'm now at, having gone through Deakin, now at Waikato. So we all move and change. But what's important about this work is that we were funded through ANROS to really start understanding what is happening in these services in relation to women with disabilities. We did this research collaboratively with women with disabilities, and the poster that you can see on the side was one of the key outcomes of this research, where we worked with a group of people with disabilities, some of whom have been on our community advisory board, and others we recruited specifically to the role of developing the knowledge translation from this research. I'll work through that poster with you in a little while, but it's important. It's not just there to make the slide look nice. It's actually our key knowledge translation output from this research, co-developed with women with disabilities. But what did we find when we did this research with the domestic and family violence services? And there are 4 big ideas: that if services are going to be accessible, and they need to be, obviously, all of these services said to us we should be expecting to see many more women with disabilities in our service than we are. So there is a problem here. Given the statistics, all domestic family violence and sexual violence services, unfortunately, should be expecting to see many, many women with disabilities in their service. What they said to us is, well, we're not, and that's a problem, but also we may be missing that women do have disabilities because of our narrow view about what disability means, or we may be not even attending to the specific needs and requirements of women with disabilities because of this sort of different view we have about disability. So what they were saying is things like, well, we might only be thinking that disability is if a person is in a wheelchair, or if a person uses sign language, or if a person has a visual impairment and comes along to us with a guide dog. But there's so much more to it. So understanding disability in a more nuanced way is what we came up with, was really important. And that services, and this includes all tertiary response services, so hospitals, domestic family violence services, refuges, the police, so criminal justice responses as well. What our research suggested is all of these services need to think about how they understand disability, use an intersectional lens to do this, so that a person coming might fill in a form and say, I'm Indigenous, but they might not fill in the form that says I have a disability. Does this matter? No. What matters is that we understand the whole experience of the woman and accept and expect that, in fact, disability may well be part of their experience. So disability is not always the dominant identity, but we need to challenge these deficit impairment-based understandings so that we don't always just say, oh, if you have a physical disability, we will recognise you as disabled and we will respond. So we need to listen to and engage to the person, not the disability. and understand that an experience of disability and experience of violence and abuse are very closely linked and very much intersect. And it's at those places of intersection that we need to think about what's going on for people who have experienced violence and abuse. So the analogy or the metaphor for the poster is a T-shirt, and it says one size does not fit all, just like a T-shirt. So one of the women with disabilities who was a researcher came up with this idea, and we ran with it in relation to how we wanted to think about this. So there is no one size to fit all in disability. Disability is situational. It is experienced in relation to barriers that exist in the world and an intersecting experience of those barriers and the impairment-based experiences of people with disabilities. You'll also see that the story says the service fits if it feels right for you, just like a well-fitting T-shirt. All of these ideas came from women with disabilities. So domestic family violence and sexual violence sectors do work that is really good and is really informed from long years of experience and many layers of experience around understanding what violence means. It's often women-centred, and it has principles that foster inclusive approaches. What our research found is everyone needs to build on these approaches and translate these tertiary responses to people with disabilities. So it's not different when it's a woman with disability. It's the same. It's about using those very well-grounded and that expertise that people have to ensure that the very best opportunities are put to women with disabilities that those services have to offer. I guess one of the biggest ideas about this is the understanding of a more nuanced understanding of access. So developing a better alignment between what women with disabilities need and what services offer. And the next slide, I'll quickly go to that. But this is about using and thinking about what access feels like, is, and can be, not from ideas about standards of buildings, that's important, but going much further than that. The fourth area was about cross-sector collaboration. And this was a really big finding from our research in that services themselves says we don't do enough. We see women with disabilities as clients, but we stop there. This is about really challenging protective approaches and developing flexible approaches that focus on the relational components of what it means for people to come and use domestic family violence and sexual violence services, and breaking out of silos around that and saying, let's work together. So this is the idea of how it's spoken about in this poster is that you don't have to take your T-shirt and show it everywhere, that you can just put the one T-shirt on and seamlessly move from service to service, and you are understood wherever you go. So access, just to sort of focus around this, what does access mean? And it is more than getting into a service. So we drew on the work of Levesque, Harris and Russell that looked at access to health services and not just around disability, it was broadly around access, to come up with these 4 A's around access. Now, this is framed within Article 9 of the UN Convention on the Rights of People with Disabilities. It says all services in communities must be accessible. It draws on ideas from universal design, but as I said, universal design can sometimes be really narrowly understood. And there's real problems with this, particularly in health and community settings. So those of you listening to this who work in health and community services cannot just rely on ideas of universal design and say, okay, tick that box and we're right. It's important, but it sits under a much broader concept of access. Our research found in the services that we looked at with domestic family and sexual violence services that this narrow focus on physical access was really problematic. Often they didn't get it right anyway, but also it then said, this is how we understand disability, where in actual fact, most women with disabilities who were accessing services had cognitive or psychological disabilities. So, you know, there is no ramp that can actually respond to that. So it called for broader programmatic access. That means everything that's possible that this service can give a person needs to be available to a person with a disability. And as I said earlier, it's about understanding disability as situational and in place. So these 4 A's are, and remember this is from the perspective of people with disabilities, women with disabilities, is the service approachable? This means that women know the service is there, that you can find it, you can get it, and you can feel okay about going there, in the words of women with disabilities who developed this resource. That it's acceptable and appropriate. This means that it fits for the woman. She gets to say if it's working for her. Okay, so near enough's not good enough. That it's affordable, big issue. It should not cost you money to get there, to be there, and to go as often as you need to go. So think about this translating to hospitals. Think about it translating to refuges. Think about it as translating to other safety services, and how we need to branch into the broader community of support to think about how we make these affordable. It's a big barrier. If you can't afford to go there, you won't think it's for you. You won't even look for it. And that it's available. This means that it's there for you and you can use it like other women do. So it's there, and it says, when you look at it, this is for me. If I'm experiencing violence and abuse, this service is for me. So the references for this work come up on the last slide, and we're very happy to talk to you about this work and other work that we've done in relation to responding to sexual violence. So Amie, do you want to finish us off with this one?
Yes, thanks, Patsie. What we hope to present to you, really, to end with, is some key messages that I think you've seen demonstrated throughout the work that we've drawn on today. And they are that we look forward and we encourage you to continue to engage with an interactional understanding of disability, one which considers the fullest version of the environment and how that relates to the situational experience of disability, and to also take an intersectional understanding of disability to inform your practice. We also hope that you can receive our message about including a disability lived experience of violence and abuse where you can in primary and tertiary prevention. We've given examples of both of those today as it relates to people with intellectual disability. We encourage you to develop cross-sectoral partnerships where possible, because we understand that those through the form of a community practice, which again include people with disability, present opportunities for continuous improvement, including co-design and co-delivering approaches and responses in your area. And we suggest to you that you consider that work around the 4 A's to develop a more nuanced understanding of access to really inform your work ongoing. So thank you very much, everybody. On these slides, you can see our references, and on the previous slide, both of our contact details, as well as the Sexual Lives Respectful Relationships site. We look forward to hearing from you in the live Q&A and discussing this more.
Thanks very much, everybody, and kia ora.